Good day everyone. Today our topic of discussion is basics of single ventricle. We will be discussing its anatomy and physiology. Today we will be discussing about single ventricle as a concept, related terminologies, anatomy of unpalliated and palliated single ventricle defects, physiology, preoperative and postoperative physiology of single ventricle defect, physiology of post-Fontan complications, and some food for thought questions lastly. Before discussing about single ventricle, let us start with normal anatomy and physiology. So normal is biventricular in series separated circulation. I repeat, normal is biventricular in series separated circulation. Two ventricles, LV and RV, supplying two separate circulations, systemic and pulmonary. That's normal biventricular circulation. But have you ever wondered why we need biventricular circulation? So let us start with some very basic biology. Let us go on a journey to more than 500 million years back. We as humans, as mammals, we are endotherms and we can maintain our core temperature, right? So mammals perform complex functions, and as endotherms we require more temperature. We need to maintain our temperature. So more temperature requirement means more metabolic rate. More metabolic rate requires more ATPs, and a crucial step of ATP production is requirement of oxygen. So more oxygen is required, right? So now there is far more oxygen in air than in water, obviously. So we as vertebrates have evolved over millions of years, from fishes with gills breathing underwater to higher species including mammals with lungs breathing air. So that is air breathing and permanent land living due to higher oxygen content in air. Now lungs as specialized organs are required to extract more oxygen of air. So more oxygen, more ATP, it sustains homeostasis basically. So there are two separate circulations, systemic and pulmonary. Separate circulations prevent mixing, hence more oxygen is there and no cyanosis is there. From evolutionary biology perspective, all this is a little too simplistic, but it serves our purpose for basic understanding. Now, as we have established that separate pulmonary circulation and lungs are important, but why a separate ventricle is needed? So what is the importance of right ventricle? So basically two ventricles, two very different tasks are there. High pressure LV for higher SVR needed for control of oxygen delivery, and low pressure RV for low PVR needed for oxygen exchange. Two separate ventricles for two separate requirements. At rest, RV keeps systemic venous and RA pressures low, and during exertion it accelerates pulmonary flow in a pulsatile manner and increases cardiac output. Pulmonary pressures can normally increase up to 50 mm of mercury or even more during exercise, leading to recruitment of lung vessels. This will also allow some compensation in disease states such as any lung disease that may result in increased pulmonary vascular resistance. Now, as we will further see, most common single ventricle defects affect right ventricle. Why? So let us have a basic understanding of evolutionary biology. Most human congenital heart diseases consist of anomalies of one or more components of right ventricle. Malformations of the left ventricle are relatively infrequent. Fish and amphibia do not have a right ventricle. Only higher reptiles and mammals have right ventricle. The comparatively recently evolved right ventricle in our evolution is only about 36% as old as LV. So RV is basically somewhere around 180 million years old versus the appearance of LV 500 million years back. So congenital heart disease is the commonest anomaly in live-born infants. It also accounts for more than 20% of all spontaneous abortions. Thus, we are still having trouble with our major cardiovascular evolutionary adaptations to air breathing. We are still having trouble with our major cardiovascular evolutionary adaptations to air breathing, like development of right ventricular sinus. So basically right ventricle, we will discuss why I have written right ventricular sinus, and septation to separate the systemic and pulmonary circulations. Interspecies cardiac evolution in embryology, what is it? It is indeed true in case of CHD that ontogeny recapitulates phylogeny. Most of the cardiac defects, and in our case single ventricle defects, are arrests in developments. Initially, during cardiac development, there was in series circulation at single layer heart tube stage, then it progresses to in parallel circulation only to finally become in series circulation again. DILV, AV canal defect, common inlet ventricle, tricuspid atresia type circulation are all present at some point in normal human development. This is the basic embryology of single ventricle defects. So till now we discussed why biventricular and how did we achieve biventricular circulations. Next is what is biventricular. The need for partitioning of two circulations, systemic and pulmonary, and two pumps LV and RV, both of which are generally not fulfilled in case of single ventricle. Here one of the ventricle is unable to sustain either systemic or pulmonary circulation. A heart may be functionally univentricular because of its anatomy or lack of feasibility or lack of advisability of surgically partitioning the ventricular mass. A heart may be functionally univentricular because of its anatomy or lack of feasibility or lack of advisability of surgically partitioning the ventricular mass. So now there are plethora of terms indicating more or less the same thing. Multiple terms are there like single functional ventricle, univentricular heart, single ventricle, univentricular AV connection, or functionally univentricular heart. So what is the definition of single ventricle? So according to International Classification of Diseases, the term accepted is functionally univentricular heart. Alternative terms are single ventricle and univentricular heart. So definition according to ICD-11 is a spectrum of congenital cardiac malformations in which the ventricular mass may not readily lend itself to partitioning that commits one ventricular pump to the systemic circulation and another to the pulmonary circulation. From a surgical point of view, single ventricular physiology exists when there is impossibility or inadvisability of surgically reconstructing a functional two ventricular heart with in series separated systemic and pulmonary circulations. For practical purposes, it means that patient is on Glenn-Fontaine pathway. Now, what are the common lesions in single ventricular anatomy? They can be divided into two parts. One is true single ventricle, in which there is it is impossible to achieve biventricular circulation, and another is functional single ventricle. It is inadvisable to achieve biventricular circulation. So what are the true single ventricle lesions? When one of the AV valve or ventricle is either hypoplastic or rudimentary. Examples are double inlet connections. Double inlet connections are the presence of single common AV valve or two separate valves that drain predominantly into one ventricle, like DILV, DIRV, unbalanced AV canal defect. Then next is absent connections. Absent connection is one of the AV valve is atretic or absent. These leads to formation of two different ventricles. One is small and hypoplastic and the other is of good size. That is like in HLHS, tricuspid atresia, mitral atresia. Then there are hearts with normal AV and VA connections. Atrioventricular and ventricular arterial connections in which one ventricle cannot sustain the systemic or pulmonary circulation. Example is pulmonary atresia intact septum, in which heart is when RV is monopartite, or extreme forms of Epstein, that is Carpentier type C and D. Next, functional single ventricle, where it is inadvisable to achieve biventricular circulation. Inadvisable either because it's very complex or there are likely concerns about optimal functioning of AV valves or ventricles post correction. Examples are straddling AV valve, complex DORV cases, some forms of crisscross ventricle, and very large VSD amounting to single ventricle. Before going further, let us clearly understand some basic terminologies. So first of all, what is ventricle? Sinus or inlet part makes ventricle. That means no sinus or no inlet, no ventricle. So ventricle definition is chamber which is receiving more than 50% of inlet. Now we must have heard terms like sinus, inlet, outlet, trabecular, outflow parts. There are multiple terminologies are there. So basic is that initially RV was thought to have only two parts, sinus, that is inflow, and outflow. Over the period of time we learned that there are three parts of RV: inlet, trabecular or muscular part, and outlet portion. Ventricle is something which receives more than 50% of inlet. What is rudimentary chamber? It is chamber that receives less than 50% of inlet. What is outlet chamber? Rudimentary chambers consisting of an outlet portion. What are trabecular pouches? Those possessing only a trabecular area or zone. bulboventricular foramen, the communication between the dominant ventricle and the accessory chamber is called bulboventricular foramen. Remember that VSD is basically an interventricular septal defect. It is interventricular septal defect. So there has to be two ventricles for VSD to be there. So in case of bulboventricular foramen, there is one dominant ventricle and another is rudimentary ventricle. Lastly, what is indeterminate single ventricle? Indeterminate single ventricle is that where morphology does not fit into either RV or LV type. Moving forward, now we will be having a look at a few basic anatomies of single ventricles. So this is a case of hypoplastic left heart syndrome in which hypoplastic mitral valve is seen, aortic valve is nearly atretic and there is severely hypoplastic LV. So it is impossible to achieve two ventricular circulation in such cases. This is a case of DILV. DILV is double inlet connections. Double inlet connection means there are two AV valves, mitral and tricuspid, both opening into a single ventricle. This is another example of DILV. Both AV valves are opening into this ventricle from which PA is arising. This is LV, LV is giving rise to PA and this is the outflow chamber which is giving rise to aorta. This is hypoplastic chamber. This is LV, this is hypoplastic chamber. The communication between these two is called bulboventricular foramen. This is example of tricuspid atresia. This is mitral valve, this is tricuspid valve which is not made, that is atretic tricuspid atresia. This is example of unbalanced AV canal defect. This is example of extreme form of Epstein. This is atrialized right ventricle. This is RA and there is severe TR is seen. Tricuspid valve has moved so down into RV apex. So there are some common associations of single ventricle defects. Several other anatomical aspects which play crucial role in decision making in single ventricle besides single ventricle anatomy itself, like isomerism, right isomerism versus left isomerism, TAPVC which is commonly associated with single ventricle defects, extracardiac or intracardiac TAPVCs. Extracardiac TAPVC generally associated with right isomerism while intracardiac TAPVCs are generally associated with left isomerism. AV canal defects, commonly unbalanced AV canal defects, pulmonary atresia, arch hypoplasia or interruption. Now moving to anatomy of palliated defects, post-surgical anatomy. These are the images of BT shunt and Seno shunt which are done in case of single ventricle, not just in case of single ventricle but in certain cases of single ventricle anatomy. So this is the right BT shunt connecting right subclavian artery to RPA. If it is done on left side connecting left subclavian to LPA, then it is left BT shunt. This is Seno shunt, that is a tubular graft between RV to PA. This is Glenn and Fontan circuit. So basically what is Fontan or Fontan cruiser operation? It refers to any operation that results in the flow of systemic venous blood to lungs without passing through a ventricle. Now in Glenn shunt, there is superior vena cava is connected directly to the right pulmonary artery, and in case of Fontan, there is IVC is connected via extracardiac graft, that is extracardiac Fontan, extracardiac graft to branch pulmonary artery. What are some of the changes seen in anatomy post palliative surgeries? Post PA band, bulboventricular foramen restriction can progress. There is something called bulboventricular foramen area index. In certain studies, it has been found that less than 2 cm² per meter square of bulboventricular foramen area index is associated with bulboventricular foramen restriction post PA band surgery. Then branch PA stenosis can occur. Post BT shunt or central shunt, branch PA stenosis or unequal PA growth can be seen. Post Glenn and Fontan, LV remodeling can be there. Next, moving to single ventricular physiology. What is single ventricular physiology? Complete or almost complete mixing of systemic and pulmonary venous blood, and then ventricle pumps blood to both systemic and pulmonary circulation, that is parallel circulation. Complete mixing or almost complete. We will discuss further that what is almost complete or why I have mentioned it is almost complete in certain cases, but otherwise for a general purpose it is complete mixing of systemic and pulmonary venous blood, and then ventricle pumps this blood to both systemic and pulmonary circulation, that is parallel circulation. Distribution of systemic blood flow and pulmonary blood flow depends upon SVR, systemic vascular resistance and pulmonary vascular resistance. Single ventricle physiology is essentially an admixture physiology. Admixture is seen at RA level in case of mitral atresia and HLHS, at LA level in case of tricuspid atresia and PIVS, at ventricular level in case of DILV, DORV and double inlet right ventricle. Admixture physiology, as a result of complete mixing, aortic and PA saturations are same. So if pulmonary venous saturation is 100% and there is normal systemic blood flow, arterial saturation will reflect pulmonary blood flow. I will repeat. As a result of complete mixing, aortic and pulmonary artery saturations are same in case of admixture physiology. So, if pulmonary venous saturation is 100% and there is normal systemic blood flow, arterial saturation will reflect pulmonary blood flow. For example, if SVC saturation is 50% and aortic saturation is 75%, QPQS ratio comes out to be somewhere around 1. If SVC saturation is 65% and aortic saturation is 90%, QPQS ratio comes out to be somewhere around 2.5. Assuming that pulmonary venous saturation is 100% and SVC is 70%, saturations and QPQS are plotted on graph. So at saturation of 80%, 0.5 is to 1 QPQS ratio is there. At 85% saturation, ratio becomes 1:1. At 90% saturation, ratio becomes 2:1. At 93% saturation, ratio is 3:1. And at 94% saturation, QPQS ratio becomes 4:1. So we can appreciate the rapid rise in pulmonary blood flow with every 1% rise in saturation post 90% of saturation. It is quite so. Let us discuss something about relationship between saturation and QPQS. It is quite clear that at low QPQS, a small increase in pulmonary blood flow causes larger increases in saturation, but with increasing pulmonary blood flow, much smaller increase in saturation occurs. We can see here that at low saturation levels, a small increase in QPQS results in large increase in saturation. So curve is initially steeper and then it flattens out. So increasing QPQS does not increase saturation later. So increasing QPQS, increasing pulmonary blood flow from 2:1 to 4:1 gives rise to a very modest rise of 2 to 3% in saturation. This is the rationale behind BT shunt and PA band also. So take for example of BT shunt. When saturations are very low, BT shunt is done. BT shunt causes small increase in pulmonary blood flow and causes larger increases in saturation. But this happens in initial part of curve. In later part of curve, increasing QPQS or pulmonary blood flow basically does not increase saturation as such. It only leads to excessive volume overload and in turn heart failure. So what are the clinical implications of all this? So basically, saturation more than 85 indicates increased pulmonary blood flow, which can lead to alveolar edema, impaired gas exchange and increased PVR, while saturations less than 75% are associated with cyanosis and decreased pulmonary blood flow. So QPQS ratio will affect volume overloading of single ventricle and saturation, and vice versa. SpO2 will affect QPQS ratio. So discussing about physiology of single ventricle. Physiology of single ventricle depends upon obstruction to outflow, obstruction to inflow, AV valve regurgitation, pulmonary circulation and pulmonary vascular resistance, and ventricular function. So obstruction to outflow can be seen in case of pulmonary stenosis, pulmonary atresia, coarctation, aortic stenosis, hypoplastic arch, restrictive bulboventricular foramen or restrictive PDA. Obstruction to inflow can be seen in case of obstructed TAPVC in cases of heterotaxy, restrictive ASD in case of tricuspid atresia or mitral atresia. AV valve regurgitation can be seen in case of single ventricle due to multiple causes like annular dilatation, AV valve morphology, hypoxic damage to subvalvular apparatus, changes in loading conditions, and ventricular dysfunction. Pulmonary circulation and PVR are affected, and they also affect single ventricle in multiple ways. So, abnormal pulmonary vascular growth and development, effects of surgical scarring, endothelial dysfunction, collateral flow, non-uniform flow distribution to lungs, and stenosis resulting from ductal constriction, all these factors affect pulmonary circulation in case of single ventricle. Ventricular function is greatly affected in case of single ventricle. Hearts with two ventricles, each ventricle augments the function of other ventricle, that is in normal. Ventricular-ventricular interaction results from coupling of the two ventricles through the interventricular septum and through an anatomic continuum that joins the mural myocardium of the RV and LV. Ventricular interdependence does not occur unless a right ventricle contributes to the left ventricular function and a left ventricle contributes to the right ventricular function. Accordingly, ventricular interdependence does not exist in univentricular hearts. The result is abnormal systolic and diastolic function irrespective of the morphology of the single ventricle. What are some of the causes of ventricular dysfunction? Aortopulmonary shunts like BT shunt result in increased ventricular volume load. Valvular regurgitation causes hemodynamic stress on myocardium. Myocardium is subjected to chronically hypoxic environment. Morphological RV or indeterminate anatomy. Even in those with single left ventricle, normal geometry as in a two ventricle system is not preserved. Myocardial fiber arrangement in the single ventricle is often disturbed and myocardial fibrosis is present. As a consequence, ventricular energetics and the mechanics of contraction can be deranged. Thus, as we discussed earlier, there is complete admixture is seen in case of single ventricle lesions, but in certain cases like there is not complete admixture is there. Example is streaming. Blending of blood from both systems in same chamber, so final saturation is generally average of systemic and pulmonary venous saturations, but in some cases streaming of blood, that is direction of blood flow into a particular great vessel is seen. The pulmonary venous return can preferentially stream into aorta, precluding complete mixture and result in higher oxygen saturation in aorta than pulmonary artery, that is called favorable streaming. Favorable streaming is seen in DALV with aorta from left-sided outlet chamber. High saturation, oxygenated pulmonary venous blood goes directly to aorta, leading to increased saturations. Conversely, the pulmonary venous return can selectively enter the pulmonary artery, resulting in higher saturation in PA than aorta, that is called unfavorable streaming, leading to excessive desaturation. So, unfavorable streaming is seen in case of DILV with aorta from right-sided outlet chamber, low saturations as oxygenated pulmonary venous blood is going into PA instead of aorta. Thus, it is apparent that for the identical pulmonary blood flow, saturation can vary considerably depending on the streaming in the common mixing chamber. So, let us discuss about some of the terminologies associated with single ventricle physiology. Initially, earlier we discussed about terminologies associated with single ventricle anatomy. Let us discuss certain terminologies of single ventricular physiology. First is balanced circulation. Depending upon systemic vascular resistance and pulmonary vascular resistance, there is QPQS of 1 or equitable pulmonary and systemic perfusion is there. That is called balanced circulation. Here QPQS is close to 1. A balanced circulation results in maximum oxygen delivery, that is DO2, at the tissue level without causing heart failure. But there are certain situations in which while the circulation is balanced, that is QPQS of nearly 1, they represent a precarious clinical scenario. A patient with a mixed venous saturation of 25%, pulmonary venous saturation of 95% and aortic saturation of 60% has a balanced circulation. The QPQS ratio is 1, but nonetheless he has severely impaired systemic oxygen delivery. So ideally, balanced circulation term should not be confused with stable hemodynamics. This is more of a misnomer. Next is parallel circulation. So these days, more preferred term is multi-distribution circulation, because a truly parallel circulation should be reserved for neonates with TGA, transposition of great arteries. More accurately, these functionally univentricular hearts must distribute the ventricular output to both the pulmonary and systemic vascular beds, and if there is atrioventricular valve regurgitation, so that is QP plus QS plus QR, all these three are distributed by the single ventricle, so that is more of a multi-distribution circulation. Now this multi-distribution circulation is inherently inefficient and results in progressive congestive heart failure over time. As can be seen in this image, the variability in efficiency is dependent on anatomy, ventricular function, valve function, pulmonary parenchymal function, systemic and pulmonary vascular resistance, ductal patency, and status of surgical connections. So multiple factors affect this circulation. Next is pulmonary overcirculation. So these days preferred term is circulatory maldistribution. Increased pulmonary blood flow per se in the face of normal systemic blood flow and normal pulmonary parenchyma may have no physiologic consequences. For example, in a patient with mixed venous saturation of 65%, pulmonary venous oxygen saturation of 95% and aortic saturation of 85% has a QPQS ratio of 2:1. So pulmonary blood flow is nearly 2 times the systemic blood flow. However, systemic oxygen delivery is maintained as evidenced by a normal mixed venous oxygen saturation and a narrow difference between the arterial and venous oxygen saturations. So these days preferred terminology is circulatory maldistribution instead of pulmonary overcirculation. Next is what are the physiological basis of staged palliation? Aim of staged palliation is to create in series separated circulation as against in parallel circulation, which was previously there. Glen circulation is a in series circulation, although with a obligate 40 to 60% of right to left shunt from IVC to ventricle and eventually to aorta. Fontan circulation is also a series circulation with systemic venous return entering the pulmonary vascular bed in series. This is done to counter two main drawbacks of single ventricle physiology, that is increased volume overload and cyanosis. So let us first discuss about transitional physiology. Dramatic changes in physiology seen with transitional circulations like decreased PVR, progressively increasing pulmonary blood flow, increasing systemic ventricular afterload, closure of ductus arteriosus with time, and foramen ovale. All these changes are seen in first 1 to 1.5 months of life. In neonates result in hemodynamic abnormalities that are quite variable depending on the individual anatomy of different lesions. In case of single ventricle with unobstructed pulmonary blood flow, as the PVR continues to fall, higher proportion of the ventricular output is directed to the pulmonary vascular bed and the volume work of the ventricle increases. Eventually leads to signs and symptoms of congestive heart failure. As a compensatory mechanism to CHF, systemic vascular resistance rises, further redirecting blood to the pulmonary vascular bed which was already overloaded, further worsening heart failure. In case of single ventricle with obstructed pulmonary blood flow, as the ductus closes, QPQS progressively falls and saturation also starts falling, leading to severe cyanosis. What is the rationale behind stage 1 surgery? So aim of stage 1 surgery are multifold. First is complete intracardiac mixing of oxygenated and deoxygenated blood by way of non-restrictive ASD, which eliminates streaming, relieves pulmonary venous and systemic venous obstruction, inflow obstruction. Next is pulmonary blood flow should be balanced. Balanced pulmonary blood flow means we have to balance between cyanosis, increasing cyanosis, or increasing heart failure. So we have to balance between these two. Next is unobstructed systemic blood flow, which leads to adequate oxygen delivery to tissues. When saturations are low due to decreased QP, BT shunt is done. As we have discussed earlier, BT shunt causes small increase in pulmonary blood flow and causes large increases in saturation. When saturations are high in increased QP conditions, PA band is done. PA band markedly reduces pulmonary blood flow and in turn volume overload by causing a small decrease in saturations. What are the bases of BT shunt versus Seno shunt? So as PVR normally falls with time, increasing continuous flow through a patent BT shunt causes fall in diastolic pressures and hampers coronary perfusion. Seno shunt occurs only during systole, so better coronary perfusion is there. Though there is risk of focal ventricular scarring and arrhythmias with Seno shunt. So let us discuss rationale behind Glen and Fontan surgery. So PVR continues to decline with age, leading to increased pulmonary blood flow, and there is risk of pulmonary overcirculation with passing time. So Glenn and Fontan surgeries basically achieve both the goals of treatment of single ventricle: volume unloading of single ventricle, and they also improve pulmonary blood flow, increasing saturation. So these this also allows for gradual ventricular remodeling. Fontan circulation is based on a premise that a subpulmonary ventricular pump is not compulsory for venous return to cross the pulmonary vascular bed. Rather, pulmonary blood flow and thus the preload to the single ventricle can be driven by moderately elevated central venous pressure when pulmonary vascular resistance is low. So, what is Fontan principle? Fontan principle is that no pumping chamber in systemic venous circulation is there. Pulmonary blood flow is maintained by transpulmonary gradient between mean PA pressure and pulmonary venous pressure, and in turn LVEDP pressures. A low LVEDP and transpulmonary gradient provides the pressure differential for pulmonary blood flow. It would be interesting to note here that no other species have evolved such circulation over millions of years of evolution. No other species has similar circulation to Fontan. So what are some other rationale why we don't do Glenn and Fontan together? Staged procedure allows for better ventricular remodeling. So ventricle passes from hypertrophied and dilated ventricle initially to underfilled and contracted ventricular post surgery. It also allows for upper body systemic and lymphatic venous system to adjust to increased venous pressures. Why don't we do Glenn first? Why do we do Glenn first and Fontan later? Why don't we do Fontan first and Glenn later? So it is basically depends on proportional distribution of cardiac output to brain is highest in infants. So systemic venous return via SVC is 50 to 55% till 2.5 years of age, and then it decreases to adult values of 35% by 6 years of age, when generally there is Fontan completion is done at 4 to 6 years of age. What is Glenn physiology? Glenn physiology is QPQS post BD Glenn shunt is generally 0.4 to 0.6:1, as SVC is returning half of the systemic cardiac output in young children. So final saturation comes somewhere around 80 to 85%. Ventricle is unloaded after Glenn as it only pumps QS now. It was initially pumping QP, QS both. Now it is only pumping QS. So prior to the procedure, single ventricle distributes QP, QS and regurgitant volume also, and immediately after procedure, ventricular volume decreases significantly as it is only pumping QS, and if regurgitation is then QR also, whereas the mass does not regress. These results in acute mass to volume mismatch and can transiently cause mildly decreased ventricular dysfunction, mildly decreased ventricular function. QP is dependent upon SVC pressure. So QS is dependent upon ventricle, QP is now dependent upon SVC pressure. So upper body has an acute elevation in central venous pressure. Acute change in venous pressure results in increased ICP to explain the transient irritability and Cushing response, that is systemic hypertension and relative bradycardia frequently seen following Glenn. What is concept of antegrade flow? So if MPA ligation is done along with Glenn, pulmonary blood flow becomes non-pulsatile. So decreased capillary recruitment is there, increased pulmonary vascular bed impedance can be seen. Advantages of leaving antegrade flow across MPA open are better PA growth due to pulsatility, increased saturations and lowering of PVR because of salutary effects of pulsatile blood flow. While disadvantages are higher Glenn pressures and persistent volume overload on the single ventricle. What is Fontan physiology? Fontan is the first in-series circulation in case of single ventricle. QP is equal to QS, so now QP-QS ratio is 1. Ventricle supplies QS, systemic venous pressure supplies QP. This is characterized by absence of adequate subpulmonary ventricle. Caval veins are connected without a pumping ventricle to the pulmonary arteries. Fontan can be called an active circulation with 3 resistance beds: systemic vascular resistance bed, cavopulmonary connection and pulmonary vascular resistance bed. The pulmonary circulation is imposed between the systemic venous return and the systemic ventricle, thereby imposing a precardiac flow limitation to the systemic venous return, causing upstream congestion and decreased downstream flow. So basically 2 issues are there. There is upstream congestion and decreased downstream flow. This leads to elevated systemic venous pressure and chronically decreased cardiac output. These 2 features are root cause of pathological impairment seen with Fontan circulation. What are these 2 features? Elevated systemic venous pressure and chronically decreased output. Fontan physiology is a state of chronic physiological heart failure. Why? Because a well accepted definition of heart failure is the inability of the heart to meet resting and exercise demands at low filling pressures. Low filling pressure is very important here. By such a definition, essentially all patients with Fontan circulation have a physiological form of chronic heart failure from the first day after the operation. What are post-Fontan changes in heart? Post-Fontan, ventricle evolves from being volume overloaded, overgrown and overstretched to volume deprived with a smaller cavity and increased wall thickness. This creates a ventricular mass to volume mismatch, leading to systolic and diastolic dysfunction. There is exercise-induced increase in stroke volume is absent because of preload restriction. Chronic volume deprivation with lack of fiber stretch leads to decreased contractility and increased muscle stiffness, results in increasing filling pressures and increasing LVEDP. Also, there is exercise-induced episodic high flow and high pressure are absent. Lack of exercise-induced vessel recruitment is not there, vasodilatation is not there. So, these all leads to increasing PVR with time. So, there is increase in LVEDP with time, there is increasing PVR with time. What are the Fontan effects on other systemic physiology? There is selective increase in mesenteric vascular resistance secondary to chronic heart failure and diving reflex. Chronic low cardiac output state is there. This leads to pro-inflammatory state leading to altered enterocyte membrane permeability and causing leakage of intestinal lymphatics and loss of protein into intestinal lumen, leading to serum oncotic pressure decreases and there is systemic edema is there. High CVP leads to arterialization of hepatic blood flow. Cyanosis, inadequate nutrition, prothrombotic state and potential for right to left shunting, all these leads to lifelong risk of chronic cerebrovascular, microemboli and stroke. What is the rationale of Fontan fenestration? Fontan fenestration is a communication made between Fontan conduit and RA. Whenever there is rise in pulmonary vascular resistance, blood decompresses via this fenestration into right atrium to systemic circulation eventually without going through pulmonary circulation, leading to a small right to left shunt. This is basically a trade-off. So it reduces volume overload at the cost of mild cyanosis. It acts as pop-off and prevents heart failure symptoms. But this right to left shunt is associated with its antecedent risks. Post-Glenn and open azygous vein acts same, acting as pop-off between SVC and IVC circulation in case of rise in CVP at the cost of desaturation. So what lies in future finally? Right-sided, there are studies which show that right-sided subpulmonary ventricular assist device as destination therapy, that is called stage 4 Fontan. So going back to where we started, that's evolutionary biology. Octopuses have 3 hearts. 1 central and 2 peripheral hearts pumping blood to gills. So here for VAD can pump to lungs and act as peripheral heart. Lastly, I will leave you with some food for thought questions. One question on each of the 3 topics that we discussed: evolutionary basis of single ventricle, its anatomy and physiology. So if biventricular circulation is so much better, then why do tortoises who live the longest have single ventricles? Do DORV, non-rootable VSD, who are single ventricle candidates with 2 good-sized ventricles which contract simultaneously, have better prognosis than single ventricle of RV morphology? Fontan works on premise that RV is dispensable. There are multiple studies done on this in 1940s and 50s. But what is the evidence? Just go and read all those studies. They are very important to understand.